Good afternoon, and welcome to the Alamo Breast Cancer Advocate Chat. My name is Mary Jimenez, and I'm an executive leader with extensive oncology experience in diagnostic and biotech sales. I'm also the co-founder of iConsult Group, where I'm currently consulting for several startup companies. Joining me here today is Dr. Milan Radovich. Dr. Radovich completed his undergrad in biochemistry at Purdue University and his PhD in medical and molecular genetics at Indiana University School of Medicine. Dr. Radovich is currently serving as a Senior Vice President and Chief Scientific Officer at Caris Life Sciences. He leads Caris's efforts in data-driven scientific advancements in genomic medicine, liquid biopsy, translational research, clinical trials, target discovery, and drug development. He works closely with numerous academic and biopharma collaborators on joint research and precision medicine. Before joining Caris Life Sciences, Dr. Radovich was an associate professor at the Indiana University School of Medicine and vice president for oncology genomics at Indiana University Health. Please join me in welcoming Dr. Milan Radovich. He'll be discussing the role of biomarkers in breast cancer.
Thank you, Mary, for the kind introduction. It's a pleasure to be here today doing this webinar with the Alamo Breast Cancer Foundation. Looking forward to it.
Thank you. Dr. Radovich, before we jump in, can you please share with us a little bit about the biomarkers, how they've evolved, what they are, and why do they play such an important role in breast cancer?
Absolutely. Well, as many of you are well aware, breast cancer is probably the most best example of the use of biomarkers for revolutionizing therapy for breast cancer. It really led the way in terms of development of oncology therapy using biomarker-driven approaches. Obviously, the first being estrogen receptors, which we've known can be targeted since at least the 1970s, progesterone receptor, and then obviously HER2 as we came into the 1990s. But what we've seen since then is really an emergence of a plethora of biomarker-directed approaches to attack breast cancer. So what I'd like to do is maybe begin with starting down a little bit down memory lane and how biomarkers have really revolutionized breast cancer, but really also then focus more on what's cutting edge and what's coming down the pipe. So again, I'm a history buff and I love talking about cancer history. When we think about the concept of precision medicine, i.e. targeting cancers based on the unique makeup of each patient's tumor, really started into the 1990s with the development of targeted therapies. The first being Gleevec for the treatment of chronic myelogenous leukemia. But Mary, as you well aware, the development of Herceptin in the 1990s being the second targeted therapy, again, revolutionized the treatment of HER2-positive breast cancer. As we got into the 2010s, what we saw then is an emergence and explosion in genomic technology. The ability to use cutting-edge sequencers to dissect the genomic makeup of each patient's tumor, trying to figure out what are all the things that have gone haywire in a cancer, and then be able to match therapies to those individual genomic mutations. And then if we talk about the 2020s, if you ask me, I think what is going to be the highlight of the 2020s is the use of artificial intelligence. What we know is that our technologies generate so much vast data that the human mind, no one scientist or group of scientists can ever comprehend all the potential associations or new biomarkers or new drug targets that could come out from this data. So we need powerful computers that help us analyze this data to create the next discovery. And I'll highlight artificial intelligence a little bit later. So at a high level, when we think about biomarkers, they come in three major flavors. The first major flavor is a direct biomarker, meaning you develop a drug against the specific aberration that you see in the tumor. So examples like this is Herceptin against HER2 amplifications, or more recently, I show on this example, the use of a KRAS G12C inhibitor against KRAS G12C mutations primarily seen in lung cancer and colon cancer and others. The second flavor is an indirect biomarker. This is where we observe a phenotype that's more likely to respond to an associated drug. So a great example is the use of immune checkpoint therapy in MSI high or TMB high tumors. As you know, what immune checkpoint therapy does is it blocks essentially a protein called PD-L1 that acts like a camouflage that blocks tumor cells' ability to be surveilled by the immune system. But what we know is that cancers that are highly mutated, that when you use immunotherapy, are much more elicits a much more powerful immune response against the cancer. So here, the immunotherapy is not actually going directly after TMB in itself, but because cancers have this high mutations, they tend to do better with immunotherapy, so an indirect biomarker. And then the third flavor is a pathway biomarker where we have an aberration in a pathway. So if you think about the inside of a cell, it's like a complex electrical wiring diagram, and A goes to B, which goes to C, which goes to D. And what we know is that in certain pathways, if one part of that pathway is mutated, we may not be able to go after that particular mutation, but we may be able to go, we're able to go after a target that's downstream in the pathway. So think about it like if A is mutated, we can go after C. And we've seen several of these examples. Probably the most notable example is the use of PARP inhibitors in BRCA1 mutated breast cancer. What we know is that when BRCA is mutated, these cancers are sensitive to one of another target within the same DNA repair pathway called PARP. And when we use a PARP inhibitor, we can elicit anti-tumor responses. So as I mentioned, it's a complex wiring diagram, and there are actually a ton of established and emerging targeted pathways in breast cancer. I promise you there is no quiz after this, so you do not need to memorize this really complex diagram. But what I just want to show in this is that cancer, and breast cancer in particular, has numerous aberrations, a lot of things that cause that breast cancer to go haywire. And there's multiple approaches that are both FDA approved and those are in clinical trial that are going after these particular aberrations and these pathways. Now, one thing that I think is important, and when we consider precision medicine, biomarkers, and breast cancer, is that in the end, there are no two breast cancers that are exactly the same. There's commonalities, yes, things like ER, PR, HER2, ESR mutations, BRCA, so on and so forth. But I've been studying breast cancer for over 17 years, and I will tell you, I've never seen an identical breast cancer genome between two patients. What we know is each patient's cancer is quite unique at the genomic makeup. And what's really important is that as we realize this uniqueness is that each cancer has to be approached with a comprehensive genomic approach to really figure out, again, what's all gone haywire in each individual cancer, what's making it tick, and how do we better stop it? And so we at Caris are completely aligned with what many have said publicly and in the literature, and including recent guidelines from ASCO, is that there's a rationale for genomic testing of all patients' tumors. In today's age and technology, we're able now to, again, dissect the entire exome and genome of these cancers, figure out what's all gone haywire, and make sure we match the right therapy for these patients. Now, as mentioned, what I'd like to primarily do today is kind of focus on what's kind of the cool cutting edge of breast cancer as it relates to these targeted precision medicine. Well, one thing that's really quite important and that we see mutated in a large proportion of breast cancers is mutations in something called the PI3K pathway. So interestingly, in normal biology, PI3K pathway's main role is actually in insulin signaling. So when we eat our ice cream, PI3 gets activated, helps us absorb our sugars into our cells. It's a good thing. I like ice cream, and it's a good thing. What happens though in certain cancers though is when PI3K is mutated, it actually acts like a gas pedal. It tells the cancer to continue to grow, divide, and survive. Okay, so what happens is when we see a mutation in the PI3K pathway, it's stuck in what we call in the on position, constantly telling that cancer cell again to grow, divide, and to survive. PI3K mutations in breast cancer had been known for quite a while, but it was only until very recently have we had drugs developed that go after these particular mutations. The first drug being alpelisib, based on the SOLAR-1 trial. And then more recently, last year, we had the FDA approval of a drug called capivasertib, which was FDA approved for breast cancers that have mutations in either PI3K itself or its pathway, AKT1 and PTEN. Seen here is the FDA approval and the results published in the New England Journal of Medicine from the Capitello trial that show that patients who received capivasertib plus fulvestrant, which is an anti-estrogen therapy, had a significant improvement in progression-free survival compared to those who had placebo plus fulvestrant. leading to the FDA approval of this combination in PI3K mutated cancers. So again, a beautiful example of why all breast cancers need to be genomically sequenced, because we need to identify, for example, those 35%, roughly 35% patients who have mutations in this pathway who can benefit from this particular drug. What we're also seeing is the emergence of really some of my favorite exciting area of drug development, something called antibody-drug conjugates, or ADCs. So what antibody-drug conjugates are they're antibodies. So they're proteins whose job is to bind to the cell surface of cancer cells, particular targets present on the cell surface of cancer cells. But what's unique about these antibodies is that they're linked to a payload. Think of it like a bomb. When that antibody is linked to that payload in the circulation, it's inert. But once it binds to the cancer cell internalizes it. And once it's internalized, that payload is released. The bomb is released, killing the cancer cell from the inside. And what we've seen recently is just an explosion in drug development and antibody-drug conjugates. There's just been so much effectiveness with these agents across different types of cancers. Now, in breast cancer, we've seen, again, wonderful activity on the use of ADCs. Probably some more recent examples are drugs like trastuzumab deruxtecan, which have proven to be highly effective in HER2-positive and HER2-low breast cancers, and also FDA approval of sacituzumab govitecan, which was first FDA approved in triple-negative breast cancer, but also now has seen effectiveness in hormone receptor-positive breast cancer. Again, similar approach, antibody with payload. But what we're seeing in the ADC technology has really been a maturation and an improvement both in how the antibodies work, meaning how well they find and bind their targets, but also the payload, that bomb, becoming more effective, sometimes less toxic in killing these cancer cells. I want to just highlight a couple exciting ADCs. These were presented at San Antonio last year. We've seen several presentations on these agents, one of them being datopotamab deruxtecan. This is a novel ADC against TROP2. TROP2 is a protein on the surface of a variety of solid tumors, heavily expressed in breast cancer, but also in a variety of other solid tumor cancers. What this drug does is this antibody binds this TROP2 cell surface molecule. It's linked to a payload called DXD. And like I said, when it's internalized, it kills the cancer from the inside. It also has this neat effect that we call a bystander effect, that when it kills a particular cancer cell, that payload still remains active and will actually kill nearby tumor cells in the region. And what we've seen is statistically significant and clinically meaningful improvement in progression-free survival versus chemotherapy for HR-positive, HER2-low negative metastatic breast cancer based on the phase 3 Tropion study. Another agent also is patritumab deruxtecan. They always name these drugs very difficult to pronounce. I don't know why, but they do. It's always an alphabet soup. But this is against a ADC against HER3. HER3 is similar to HER2. It's actually a sister of HER2, also present on the cell surface. Again, similar antibody binds HER3. It's linked to a DXD payload, again, having a great anti-tumor effect. We've seen beneficial activity in hormone receptor HER2 negative and triple negative subtypes based on the SOLTI, TOT, HER3, and ICARUS trials. And it's also demonstrated manageable safety profile and durable efficacy in heavily pretreated patients with advanced breast cancer.
Thank you, Dr. Radovich. Very, very informative, and it's a bonus to have your background and to be able to tie these biomarkers to therapies that are up and coming and already out in the market to serve our breast cancer patients and give them options for their treatment pathways. As we look at and how we look at these biomarkers and these roadmaps, how have biomarkers changed the course of breast cancer, and what type of tools are available to help identify these biomarkers? I mean, we know that right now, you're testing, numerous biomarkers. Can you kind of even elaborate a little bit also on the new tools like liquid biopsies and shed some light on what's being developed and what's on the horizons? Liquid biopsies have been out there for a while, liquid biopsy tests, but I think if you could focus a little bit too on how some are different and how they can rule out false positives and false negatives for our
Absolutely.
audience today.
Absolutely. Well, as mentioned, again, breast cancer is just the best example of biomarkers being completely foundational to all treatment of breast cancer. There's not a breast cancer patient today whose cancer is not being currently treated or dictated by the use of biomarkers, in particular ER/PR, HER2. But as mentioned, we now have these newer biomarkers that are particularly genomically driven that lead to drugs that have had significant effects on progression-free and overall survival. But as you mentioned, how we actually test these biomarkers have evolved as well. Traditionally, we use tissue to identify these biomarkers, but more and more, we've really transitioned to the use of liquid biopsy. So I will share here a little bit more about liquid biopsies. Some of you are going to be familiar, but probably worthwhile just a quick review on what liquid biopsies are. Now, many of you are already going to be aware of what a liquid biopsy is, but it's probably worthwhile re-reviewing the concept of liquid biopsies. So liquid biopsies are a minimally invasive approach for detecting tumor material with a simple blood draw. What we're able to do is draw a couple tubes of blood, use really sensitive next-generation sequencing techniques, and detect cancer mutations. And you may be asking yourself, how is that possible? It seems kind of Star Trek to be able to do that. Well, what's interesting is that when we think about a cancer growing or a tumor growing, we always think about this ball of cells that is growing, cells dividing and this tumor growing. But what's interesting, there's always a small portion of that tumor where the cells are dying, and they're primarily dying due to either lack of oxygen or lack of nutrients. And when those cancer cells die, they shed their DNA into the circulation. We call this circulating tumor DNA, such that, again, we can take a blood draw, we isolate the DNA from the plasma, and we can, again, use really sensitive sequencing techniques to be able to identify these mutations. Now, liquid biopsies have had a fantastic application across the entire patient disease course. They first made their first headway on the right side of the disease course in patients with metastatic or treatment refractory disease, using these techniques to identify a particular mutation where a patient may benefit from a drug. What we've seen also more recently is the matriculation of this technology to the left side of this graph to the early disease course, particularly in the MRD setting, which is using a liquid biopsy to determine if a patient's at high risk of relapse after completion of surgery and adjuvant chemotherapy, as well as for early detection, being able to use liquid biopsies to identify cancers at its earliest stages. Now, from a therapy selection standpoint, what we've seen FDA approval of a large litany of drugs where a ctDNA-based biomarker is used for guiding therapy. In breast cancer, two that, to point out is PIK3CA mutations for these PIK3CA inhibitors that I already mentioned to you as well. And another, which I'll touch on in a little bit, is the identification of ESR1 mutations, which are primarily seen in women who are resistant to hormonal therapy and the use of novel agents like elacestrant that target these ESR1 mutations. Now in breast cancer, we know a couple of really important things when it comes to ctDNA. The first thing we know is ctDNA levels in themselves are highly prognostic. So shown here are two important papers at the top, one by Dawson in New England Journal of Medicine 2013, and another one by Dan Stover from Ohio State at JCO in 2018. And both of them showed something really important, that the higher the ctDNA levels, that leads to unfortunately an inferior survival outcome. And this kind of makes sense. The higher the ctDNA level, typically the higher the disease burden. And what we know is, unfortunately, patients with higher disease burden have poorer outcomes. But what we also found out in recent years is that, again, when we identify these mutations in circulations, and treat them with a cognate drug, those patients can have meaningful responses. So that ctDNA is also not just prognostic, but it's also predictive. And probably one of the best examples of this is a clinical trial called Plasma Match that was presented by Nick Turner and published in the Lancet Oncology in 2020 that showed that you can use a liquid biopsy to identify mutation in breast cancer, treat the patient with the matched drug, and get responses against their cancer. Now, one thing that's really quite important as we begin to understand liquid biopsies is that they have some additional complexity. And one of the complexity is the issue of what we call clinical false positives. So these false positives, interestingly, they're not truly false. They're actually real mutations, but they're not coming from the cancer. They're coming from our white blood cells. It's a phenomenon we call clonal hematopoiesis, or clonal hematopoiesis of indeterminate potentials, CHIP mutations for short. So what these mutations are is that they're actual mutations, they're actual somatic mutations, but they don't come from, like I said, from our tumor cells, they come from our white blood cells. And these mutations tend to increase with age, smoking, and prior chemotherapy exposure. As I like to say, I've been, in recent years I've been graying, so I'm sure my CHIP levels are higher than they used to be 10 years ago. But anyway, we all have these CHIP mutations. They're naturally occurring. And what we know is that they occur in about 30% of cancer patients. Now, these mutations are a little interesting. They tend to occur in what we call hotspots. There's certain genes where you see them more often. And a lot of these genes, to be honest, if you see a mutation there, won't cause a therapeutic misassociation. However, there's a subset of these CHIP mutations where they do. And so this is some literature that's been published in recent years that have identified CHIP in cancer patients at different prevalences. But we can see on the right on the gene list, if you're quite savvy at seeing this gene list, what you're going to notice is there's a lot of druggable genes where we see these CHIP mutations. And so the way I like to put it to folks is that we want to use liquid biopsy to identify the right mutation to give the right drug. But what we don't want to do is give the wrong drug based on one of these CHIP mutations, meaning giving a drug based on mutation that didn't really come from the cancer. The patient's not going to benefit when you do that. So one of the really the only way to identify these CHIP variants is in addition to sequencing the plasma, where you find these tumor-derived mutations, you also have to sequence the buffy coat or the white blood cell layer. So this is an assay we developed here at Caris called Caris Assure. It's a liquid biopsy that looks at all genes in the genome, what we call the exome, both at the tumor DNA, but also in the buffy coat in that white blood cell layer. And when we sequence that white blood cell layer, we can get two pieces of information. One, we can get some information about the mutations we've inherited. So we know that certain cancers are caused by mutations we inherit from mom or dad, like BRCA1 and 2, for example, in breast cancer. But we can also identify these CHIP alterations. And again, these are a common source of interference. I always like to actually point a paper. This was published a couple of years ago. This is in different cancer. This is in prostate cancer. But what they identified is that 10% of men with prostate cancer had CHIP mutations and DNA repair genes that would have led to inappropriate use of a PARP inhibitor. I will tell you, we've got some recent data that will actually just went out for publication. We'll be excited to share later this year. But we see this prevalence in breast cancer as well with liquid biopsies, these mutations that occur in these DNA repair genes. And so what these authors rightly concluded was that clinical liquid biopsy testing should include a whole blood control to exclude these CHIP variants. It's quite important to be able to eliminate this source of false positives.
Wow, a lot has changed, and thank you for shedding some light on CHIP variants and the role it plays and what you all are doing, as I think it is important that we can safely rule out therapies, because the last thing a patient wants to do is go through a therapy to find that it's not going to be beneficial to them, especially with so many recent drugs available. You want to get the right patient, the right drug at the right time. So thank you. Very, very helpful. And it certainly has changed, and continues to evolve. Another question that has come up a lot lately is, the biology of cancer changing. So if I'm diagnosed in the adjuvant setting and then relapse in the metastatic 5 years later, my biology can change. And I think we learned that early on in HER2, that there's a percentage, 16 to 17% patients can be negative in the adjuvant and then positive in the metastatic setting. Can you shed some light on some, as to when should a patient get tested for biomarkers, and, a little bit more background on how biomarkers can change during the course of the disease, and maybe some new examples of biomarkers that actually are doing that, this newer targeted. I gave you an example of Herceptin and HER2 being familiar just in the literature, but I'm understanding right now that there are more therapies evolving that are more markers evolving rather in the in the adjuvant setting that convert or vice versa in the metastatic setting.
Yeah, absolutely. Well, again, this is yet another example of where breast cancer has really led the way, which is understanding how do biomarkers change in real time. Probably the earliest examples have been changes in hormonal subtype. We know that in about up to 25% of breast cancers, they can change from, let's say, going from HER2 negative to HER2 positive, or for ER positive to ER negative. And so it's become commonplace to retest biomarkers during the entire disease course. But another area, and an area that we've seen more recently, is the emergence of genomic changes that happen in these cancers over time, in particular to response to therapy. So one of the great examples of this is actually estrogen receptor, or the gene itself known as ESR1. So again, as this audience is going to know, 75% of breast cancers are estrogen receptor positive, and the mainstay therapy for targeting estrogen receptor is the use of endocrine therapy. So things like, tamoxifen, aromatase inhibitors, fulvestrant, and others. What we know, though, is that certain cancers will develop resistance to endocrine therapy, and one of the main mechanisms of developing resistance is developing mutations in the estrogen receptor gene, or ESR1. What these mutations do is it causes, similar to PI3K, it causes estrogen receptor to be what we call constitutively active, or constantly on, constantly telling that cancer cell to grow, divide, and survive. We know that these mutations are primarily seen only in patients who have been exposed to endocrine therapy. So it isn't actually what we call acquired resistance mutation. Again, it only really appears after having some sort of exposure to endocrine therapy. They also come in a couple different flavors. They come both as what we call point mutations, meaning a change in a single amino acid or a part of the protein to lead to this activation. But they also can appear as fusions, where ESR1 will actually literally fuse to another highly active cancer gene to lead to this kind of hyperactivated super gene to again help push cancer cell growth and survival. Now, what's interesting about ESR1 is that it's a mutation that is preferentially detected using liquid biopsy. You may be asking yourself, why is that the case? Well, if you think about a patient with metastatic cancer, so let's say there's a metastasis in the bone, or a metastasis in the liver, a metastasis, maybe a recurrence in the breast. Let's just use an example. It's not feasible to biopsy every metastasis for obvious reasons. When we do a liquid biopsy, the circulation, the blood circulation acts like a sink for all ctDNA shed from any of those metastases, so that when you sample the blood, you're actually getting a genomic sampling of all the disease, no matter where it's present. Why is that important here? Well, when you think about it, these mutations are acquired. It doesn't mean that every cancer cell has got this mutation. Interestingly, only actually a small subset of cancer cells have these mutations. And so if you tissue biopsy, you may not pick it up on tissue biopsy every time. But if you use a liquid biopsy, again, because it samples from all the different metastases, we call this tumor heterogeneity, it is able to detect these particular mutations. So when we look at the data, these mutations are by far much more prevalent seen on liquid biopsies. And actually, it's now become essentially standard of care to liquid biopsy, particularly metastatic patients who have been exposed to hormonal therapy, who've progressed with a liquid biopsy to identify if these patients have an ESR1 mutation. Now, until very recently, these ESR1 mutations were, really the bane of many oncologists, because we didn't really have effective therapies to go after tumors that had these ESR1 mutation until recently. The first FDA-approved drug against ESR1 mutations is elacestrant, approved for postmenopausal women or men with ESR mutated, hormone receptor positive, advanced or metastatic breast cancer, and key here, following endocrine therapy. Again, you typically see these after exposure to endocrine therapy. Approval was based on the results of the EMERALD trial, where we saw a significant improvement in progression-free survival in patients who had elacestrant versus standard of care going after these ESR1 mutations. And what you've been seeing in the field is just actually quite an explosion, actually, of a lot of agents right now being tested to go after these ESR1 mutations, because again, they're just so prevalent in this hormone receptor positive population.
Thank you, Dr. Radovich, for a very informative discussion. Before we close out the session today, Is there anything additional that you'd like to share on perhaps some new tools that are emerging to continue guiding us on biomarker decision making?
Absolutely. I wouldn't be a scientist if I didn't have the time to tell you what is the coolest and cutting edge. And there's a lot out there. I could point to 5 or 6 different topic areas, but one area that I would love to talk to this group about is digital pathology and AI. If you ask me in 2025, what is going to be one of the hallmarks of precision medicine, it's going to be this space. So what is this? Well, again, many of you can be familiar that when a breast cancer is initially diagnosed, there's going to be a biopsy, or when it's surgically resected, it's going to get sectioned. It's going to get stained with something called an H&E. It's going to be put under a microscope. And what that does is it allows a pathologist to look at that tissue and say, is this breast cancer? What kind of histology of breast cancer? And then subsequent to that, you'll get some additional workups we call IHCs, like ER/PR, HER2, and genomic testing, as I mentioned. Now, when we look at an H&E, like I said, its primary use is for diagnosis when a pathologist looks at it. But when a computer looks at it, it sees so much more. It sees a ton of what we call non-random features. And what this is features based on texture, shape, color, and spatial dynamics, which gives the computer a bit of information of what's going on this H&E slide. So for example, a computer can look at an H&E slide and say, okay, I see a tumor cell and it's 10 micrometers from a blood vessel, and it'll notate that. Or I see a macrophage and it's 10 micrometers away from a immune cell and another immune cell, and so on and so forth. It's capturing all this different information. And once it captures all this information, you can train using artificial intelligence for the computer to identify particular features. And so a kind of easy thing for a computer to do nowadays is for it to look at an image like this and say, okay, this part of the image is cancer and this part of the image is normal. And within these normal, these are white blood cells or lymphocytes, and these are macrophages, and these are neutrophils, and so on and so forth. Okay, so this is an easy base case. And applications like this is helping diagnose cancers using artificial intelligence. But one of the coolest things I've seen, and we've seen, this is work I'm going to show you being done at CARES, but also published it with various academic groups, is the ability to actually detect the mutation, actually being able to determine the mutation in a cancer with absolutely no genomic sequencing, okay? Just based on the image of the tissue. You may be asking yourself, how is that possible? Like, how can you look at an image and know what the DNA makeup is? And when I first saw this, I remember years ago thinking, oh my goodness, this is just modern, black magic and alchemy. But anyway, what we've come to learn is these algorithms are just kind of exquisitely positive and so powerful. So for example, maybe a couple of breast cancer examples that we can, with really high accuracy, determine if a breast cancer is PD-L1 positive with not doing any IHC by doing a scan, and within minutes a computer telling you it's PD-L1 positive, or that it's ER positive, or if it has p53 mutations, or if it has a PIK3CA mutation. And it really engenders a future where, one, the ability to rapidly identify patients for clinical trials, particularly if the biomarker is rare, maybe going through large libraries of H&E images. We also see a wonderful application to low resource settings where maybe availability of particular technologies are not as readily available, and being able to identify which patients are at high likelihood to be positive for a biomarker, and then reflex testing is another one. Another one is therapy prediction, maybe doing a better job at bifurcating which patients respond to therapy or not, both based on this digital H&E image and their genomics. So a lot of really cool potential applications with this. And you'll see a lot more coming down the pipe in the years to come in this space. And here in summary, this has just been, Mary, truly a really fun time doing this webinar. And I just want to highlight, we're in a period of unprecedented growth in precision oncology. The emergence of new pathways, new drugs, new technologies have revolutionized breast cancer to date and are going to continue to revolutionize breast cancers. Things like novel ADCs, application liquid biopsy, as I mentioned, digital pathology, are all going to revolutionize this space. We're seeing a lot of emerging targets. I talked to you about PIK3CA, I talked to you about some ADCs, ESR1, but honestly, we would need several hours to go through all of them. And there's just so much more coming down the pipe. Liquid biopsies are here to stay. They're the mainstay. They're become a mainstay technology for the detection of biomarkers, and particularly the identification of these resistance mutations like ESR1, being able to, in real time, look how cancers evolve and being able to target our therapies. We also know the importance of being able to get rid of these false positives we see in liquid biopsy or chip mutations and having to sequence that buffy coat layer to effectively do that. And then as I ended off with AI-driven pathology, I just am excited by how much insight we're going to be able to get from a simple H&E. It's going to really drive forward this field, democratize the technology to many, and a lot more excitement to come there.
Wow. Well, thank you so much. There certainly is a lot evolving in this space. And I was going to jump in there with one more question a minute ago, just because there's just such an interest in AI right now and pathology. So thank you for sharing that update on what you and other universities are doing together in a collaboration with Caris. It is important to see that continue to evolve, because we got to look for new ways to be able to identify MRD or resistancy or relapse or surveillance. And so these new tools can certainly help us, I think, get there. So really, on behalf of the Alamo Breast Cancer Foundation, thank you again, Dr. Radovich, for sharing some very valuable information today. And thank you to all the breast cancer patients that continue to advance cancer by participating in clinical trials. Thank you.
Thank you.